Welcome to this session. We know the study of trauma changes lives. We invite you to join with us as we process through this material today.
Please take a moment and review this slide with session objectives.
Brain research is showing us that healing from trauma cannot happen outside of connections. If placement outside of the home is necessary, it is important to be a connections detective while also focusing on fostering connections to the current caregivers. If it is possible for a child to safely have contact with the primary caretaker that the child has been removed from, visitation should occur and should occur in the most normalized manner possible. Keeping in mind that there is nothing normal about visiting your parent or parents or visiting your child. So just say, let's normalize this visit, if we can call it a visit, requires some thought, planning, and preparation. Why are we starting out with the word connections? We start there because true healing happens only when a child has a secure attachment. In examining connections, we look for who the child is psychologically safe with, their safe faces. We also explore physical safety. Where does the child feel safe? Their safe places. In exploring these areas, it is best to ask questions like, if you could be anywhere in the world right now, where would that be? Where would you go next? If you could plan a big party, who would you invite? Let's make a list. Safe faces and safe places. Children respond much more realistically to questions like these rather than to, who are you safe with and where are you safe? When we focus on connections, we are also focusing on physical and psychological safety. We will explore this more as we move through this session. Who do you talk to every day? Who do you add to that list in times of emergency that is not on the list of people you talk to every day? Who is your support system? Who do you share your joy with? Examining our own connections and who we share our pain and our joy with helps us center our thoughts on connections. Questions like these can be reworded to initiate safe conversations with children. Instead of engaging strictly in verbal conversations, pictures can be drawn in response to the questions. It is important to label the faces or the people the child indicates if the child cannot label the drawing him or herself. This engagement might look like the following. Let's draw a picture of the people you are used to seeing every day. You draw on your paper and I'll draw my people on mine. Now, let's share and write on our papers who these people are. Next, let's think about who has helped us out in times of emergency. Let's circle those people we think of as emergency people in our drawings and add others if we need to. Now, let's think about when something really nice happens and we are so happy. Who do we want to tell? Let's put stars by the names already on the paper for those people we always want to share good news with. Let's add anyone else that we don't have on our list that we might want to share happy things with. It's important for a trauma-informed resource parent to know who the important people are in their foster child's life. Knowing who the child's connections are and talking to the child about their connections can help foster the connection to the resource parent. The resource parent can then communicate with the DCPS staff about who is important to the child and help to facilitate contact as permissible. The important thing to remember here is that people who matter to the child should not just disappear from the child's life. It's important to note that we all bring our past traumas into our today. We want to spend a few minutes just thinking about who did we need during times of difficulty? How did those extra people help us during those times of trauma? What did you need from your extras during the time of crisis? We are just pausing here for a few moments to think about our own reactions to past trauma. Who helped you? Children living in foster care need us to purposefully think about the fact that the removal itself was or is a traumatic event. This is in addition to whatever led to the removal. Although necessary at times, removal compounds trauma. Keeping the child connected to the important people in their lives helps lessen the long-term impact of trauma of removal. We want to note here that the number 2 most stressful event for a child is to be separated from a parent. The results of the Adverse Childhood Experience Study, or ACE, indicated a link between childhood trauma and chronic diseases in adulthood, along with social and emotional problems. Results of childhood trauma include, but are not limited to, heart disease, lung cancer, diabetes, autoimmune disease, depression, violence, victimization, suicide, and an average of a 20-year shortened life expectancy. The more trauma experienced, the higher risk of health, social, and emotional problems. 2/3 of the 17,000 people in the ACE study had an ACE score of at least 1. 87% had more than one ACE. People usually experience more than one type of trauma. Rarely it is only sexual or verbal abuse. 18 states have done their own ACE surveys. Their results are similar to the CDC's ACE study. The web address www.acestoohigh.com or ace2high.com can be referenced. You will see on this slide some of the behaviors that result from ACEs being too high. There are 10 questions that make up the ACE questionnaire. We will quickly move through these questions and then explore them more in the media presentations that follow in this presentation. Did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, act in a way that made you afraid that you might be physically hurt? Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so that you had marks or were injured? Did an adult or person at least 5 years older than you ever touch or fondle you or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? Did you often or very often feel that no one in your family loved you or thought that you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? Did you often or very often feel that you didn't have enough to eat, or had to wear dirty clothes and had no one to protect you, or your parents were too drunk or high to take care of you or take you to the doctor if you needed it? Was there a biological parent ever lost to you through divorce, abandonment, or other reason? Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her? Or sometimes often or very often kicked, bitten, hit with a fist, or hit with something hard? Or ever repeatedly hit over at least a few minutes or threatened with a gun or a knife? Did you live with anyone who was a problem drinker or alcoholic, or who used street drugs? Was a household member depressed or mentally ill, or did a household member attempt suicide? Did a household member go to prison? So, what we know from the ACE study is that Traumatic experiences threaten our survival at a very deep neural level, frequently outside of the realm of human consciousness. Trauma is stored in our whole body. Trauma is not only stored in the brain. Trauma actually changes the brain. Trauma responses look like big pain-based behavior. So we want to note that all behavior is communication. Here is another way to visualize the impact of childhood trauma. This slide shows you actual brain images of a healthy 4-year-old brain and a traumatized 4-year-old brain. What we know is trauma changes the brain. What we also know is the brain can heal. The brain on the right of the screen can begin to look more like the brain on the left side of the screen. There is hope in healing. Healing happens through connections. Nadine Burke-Harris is currently the Surgeon General for the state of California. She is a pediatrician. Here's a presentation of her talking about how childhood trauma affects health across a lifetime.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together, we opened a clinic in Bayview, Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, Why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
We've talked earlier about how trauma manifests itself in behavior. We want to make note trauma results in one of these stress responses: fight, flight, or freeze. It helps to center ourselves as the caregiver to constantly remind ourselves that all behavior is communication. So, if I see this behavior, what is the child communicating? What is under this behavior? Foster parents should realize the impact of trauma and understand potential paths for recovery. Recognize the signs and symptoms of trauma. Respond by fully integrating knowledge about trauma in everyday practices. And seek to actively resist re-traumatization. Now we want to listen to Amelia Frank Mayer and her TED Talk entitled The Human Need for Belonging. Ms. Mayer has done some amazing work nationally regarding the transformation of child welfare practice in the United States.
Human beings were made to connect with other humans. It is essential not only to our thriving, but to our very surviving. Human infants are born the most vulnerable mammals on the planet. Other mammals are born and they can crawl to the food source crawl on their mama's backs and go for a swing in the jungle. But not our babies. Our babies are born and they just lay there and cry until another human being comes to connect with them. And if another human being does not come, they die. And they know it from the second they are born. Our babies need protectors in order to thrive and survive. And even when the same person doesn't come to our children in a reliable, nurturing way, they can fail to thrive and fail to grow. Our babies come ready to connect from the second they're born. They have skin so soft that you just want to hold them and cuddle them. Their big eyes look up at you, and they learn to smile early. They have little cooing noises that make us fall in love. Because when we are in love, we will do the incredibly challenging work of raising a child. We will get up for the third time in the middle of the night to feed the baby, sacrificing our own survival needs for sleep and rest in order to ensure their survival. And this is why it's not enough for children to feel only physically safe. They must also feel psychologically safe. And the way our babies feel psychologically safe is to be claimed, to belong, to have a secure protector to whom they are connected. Because they know when they have this, when we are in love, we will ensure their very survival. We come into the world literally tethered to another human being. And that need for claiming and belonging never goes away our whole lives long. But it is especially pronounced in children. We must belong to thrive and survive. We must be part of a human family, part of a tribe, in order to feel safe and protected. And when these early messages are not present, when children don't feel claimed, when they know for sure that they don't have a protector, they are left to face threats on their own. Their brain tells them, shoot, you're on your own now. And they know instinctively that they're not going to make it because they're a child. And so they go into survival brain. They are hyper-aroused, looking at everything and everyone as a threat. They lose their runway. They don't have the ability to become activated. They start at a place of hyperarousal. So every little thing sets them off. These children act like they are fighting for their lives because their brains are telling them that they are. What happens is they feel like they're on the battlefield. Like there they are, all alone. Their platoon has left them. They can hear the enemy approaching. They can hear the fire coming from the distance, but they're out of ammunition, and they stand alone in a field with a tiny little rock to hide behind, knowing full well that relying on their own defense mechanisms is not going to cut it, and their lives are at risk. And so they lose the ability to relax, to think, to learn, and most importantly, they lose the ability to connect and trust with other people because they are so profoundly consumed with their own survival. When you don't belong, it's hard to know who the enemy is. And so you push everyone away. Not knowing who will stay or go, everyone gets walled out. When you have no safe, loving caregiver, or your caregiver is compromised in some way so that you don't consistently feel loved and protected and safe, you have a diminished capacity to connect. Your brain says to you, you're in this on your own, and you know you're a kid and your survival's at risk. So trauma disrupts our capacity to connect. When we can't connect, we can't belong. And when we don't belong, we have no protection of our tribe, and our brain acts as though our survival is at risk because it is. And when we are set outside of the tribe, when we don't have the protection of others, we must rely on ourselves, which is inadequate to ensure our survival. So why is belonging so important? Not only to ensure our survival in a basic kind of way, but because belonging is wonderful. Because belonging feels like home, like safety, like I belong. You claim me. You are mine. It feels like knowing that we are deeply connected to someone that has our back, that no matter what, they will make sure that we are okay. And so we can relax. We can think and learn and connect and love and feel intense joy because we are not fighting for our own survival. Without this connection and belonging, humans will look for it because it is a fundamental human need, even when it's not good for us, such as in gangs or being vulnerable to being sex trafficked. The pain of not belonging, that profound loneliness, is so significant that people will use drugs and alcohol to numb it. They may fall into depression or despair or become so completely numb, shutting everything off because of the longing to connect, that they disconnect from all humans and become capable of the kind of violence we have witnessed on our news nearly every night. Belonging is essential to our thriving and our surviving. Now, you might be thinking at this point, she's not talking about me. Me, I have 500 plus connections on LinkedIn, another 600 on Facebook. I have lots of connections. I belong in all kinds of circles. But I'm going to tell you what my 7-year-old recently said to me, that connection is not the same as being claimed. He said to me, Mama, how many people are there in the world? How many have you seen? How many have you met? How many do you know? How many do you love? And then he said, but you belong to me. And what he meant by that was, you are my protector. You claim me. I am yours and you are mine. And we will ensure that we're okay, which is critical to his thriving. So your connections may be many, but you may be claimed by a precious few. And these people are our lifelines. They are the ones that make sure that we're okay. What if you were to land in the hospital? I'm sure you would have a lot of people on social media give you a like or a heart or say, thinking about you. How many fewer might actually send you a card? And fewer still who might take the time to come see you in the hospital. And even fewer still if it turned into a few days that you'd be there. And now what if those days turned into weeks or months? Who are the people that would be there to ensure that you were okay? It is not your LinkedIn people. It is not your Facebook people. It is the precious few who claim you as their own. And what if you did not have this belonging? What if you didn't belong to a tribe? What would that do to you? I know a girl who this happened to. And I want to tell you her story. Her name is Tarita. When I met Tarita, she was 16 years old. She had lived in 35 different placements in the previous 10 years, 13 last year alone. She came into foster care when she was 6 years old because her parents could not keep her safe. She went to live with her grandmother, who she adored. Her grandmother committed suicide in front of her when she was 6. The only person to whom she belonged, the only person who claimed her, to whom she was tethered, was gone. And Tarita was left to fight for her own survival. She came into foster care with strangers and was moved from home to home to home, each time being kept physically safe, but not being claimed. She did not belong, and she knew it. And that does immeasurable harm to humans, particularly to children. Because children do not talk their pain. They do their pain. And frankly, most of you do your pain. And what that looked like for Tarita was to feel so profoundly lonely and disconnected, so vulnerable and unprotected, that she began to act out, trying to hurt others and hurt herself. By the time I met her, she was so suicidal that she was living in a group home with one-to-one staff 24 hours a day because people were pretty convinced that she was going to be successful at ending her life. And then she became to be blamed and shamed and punished for these normal, natural responses to the feelings she was having. People would say to her, "What's wrong with you? Why can't you behave?" Not understanding that it is what happened to her, not what was wrong with her that was driving her pain-based behavior. And in fact, these behaviors were normal, natural responses to someone who thought their life was at risk, who wasn't claimed or belonged. And so as she moved each time, the people who were her caregivers, to whom she tried desperately to connect, were disrupted. And she became disconnected, and further traumatized. For her, the cure was worse than the disease. Children in foster care don't belong, and they know it. Although they're physically safe, they are not claimed, and it doesn't have to be this way. We're all born into families, right? We each have hundreds of living relatives, hundreds of people who we know and love or to whom we are related. And if your parents can't keep you safe, then it is unnatural to move you in with perfect strangers as a first round of intervention. In Native American tribes and in communities around the world, this is not how they do it. What they do is, if your parents can't take care of you, then it's your extended family. And if not your extended family, then your tribe or your community. And if as a matter of last resort, you must go live with strangers, you are still connected to your community and to your tribe. And you keep those connections because they represent protection. But what doesn't happen is moving a child in with a perfect stranger. We must do exhaustive search from the first signs of trouble with our children and our families, looking for people to care for these children the way you would look for your own baby. You would never stop until you found someone who loved them or to whom they were related. Because when children move, they don't just lose their parents. They lose their home. They lose their community, their neighborhood, their friends, their toys, their pets, the way things smell and taste and feel. And that is too much to ask of anyone, let alone a child. So remember Tarita, we were able to help her. We found her people. As a matter of fact, we found 25 biological family members living within 7 miles of her who were licensed caregivers. They had lost her. She was taken, and although they tried to call the county and find her, they were not able to. They believed that she was adopted by a loving family. And after we found them, we came to tell Tarita about this great news. And she answered the door, bandaged her head and her hands. And it's because it was family night the night before at school. And everybody had somebody to show their art projects to or their accomplishments, but not Tarita. She had nobody. And the pain was too much. And so she began to act it out. And she was physically restrained by the adults, pinned down to the ground, thrust back into survival brain. But that wasn't new for her either. That had happened 1,000 times between the ages of 6 and 9 years old. But we came to tell her that that was over. She wasn't going to be a nobody or a foster kid. She had a family. We had letters about how they had missed her and loved her, their memories of her when she was small. We had stories for her about how they had celebrated her birthday every year and had looked for her. And when it came time for our services to end, we said, "How do you want to transition?" She said, "I want a party. And I want my social worker to be there so she can see I have a family." And so we did. Balloons and cake, the whole shebang. And at the party, she came over and said to us, "You can go help other kids now. I'm going to be all right. I've got a family." Because, as you know, it is not the what's that matter. If your phone were to ring right now and you got the worst news ever, It's not your what's that will get you through. It's not your stuff or your possessions, your house, your money, your car. It's your who's. When the bad stuff happens, it's your who's who make sure you're okay. And even when you are in times of joy, it's your who's that you want to share it with. And our kids lose their who's. And it's not okay. Although Tarita's success is unique, her story is not. In 2014, 650,000 children spent time in foster care, half of them with strangers. And I'm guessing that the experience of Tarita, of not always feeling safe and protected and loved when you were little, is not only unique to her. According to a study done by the Center for Disease Control, 70% of you did not feel loved and safe and protected always when you were young. 70% of you experienced adverse childhood experiences when you were young. And what that does is makes you more prone to physical and mental illnesses. It literally makes you sick. And so what we know is that this is the root of all social ills. It is the root of our incarcerations, our teen pregnancies. It is the root of our homelessness population, of our achievement gap in part. There are all kinds of things that can be resolved because we all need opportunities to heal our pain. And we've been able to use innovative practices with these youth, these long-term, really challenging youth who people say they'll never have a family. We've been able, in demonstration projects lasting 15 to 21 months, to get 81.8% of them to their families by healing their grief and loss and doing exhaustive search for them. The foster care system is broken because it is set up to make sure that children are safe, but not to make sure that they are claimed. Physical safety is not enough. And I ask you to join me in reimagining a world where all children feel safe and claimed, especially those in child welfare, where all children claim their birthright, which is to belong to someone, belong to a protector who loves them and claims them as their own. Thank you.
So, to review so far, children who have been traumatized remain in a constant state of hyper-awareness. The child or adult can be stuck on. They remain in a constant state of hypervigilance, and they are constantly scanning the environment for danger because they expect danger. They expect threat. They anticipate an attempt to harm. The child is posed in fight, flight, or freeze. They have an urgent need to control and are ready to fight for their life. Critical need for relationships. Healing occurs in the context of relationship. Healing cannot occur if there is no significant relationship or attachment. Some notes from Amelia Frankmeyer. 10 essential things everyone should know about childhood trauma. 1. Human beings must connect with other humans to thrive and survive, especially young humans. 2. When we do not belong, we are vulnerable. 3. Helping kids safely belong is urgent. 4. When we do not feel safe and lovable, it changes our brain. 5. Connections build resilience and protection. 6. Trauma disrupts our ability to connect. 7. Children do their pain, grief, loss, and trauma. 8. Childhood trauma is pervasive and has lifelong impacts. 9. The goal of all treatment is safety and connection. 10. There is hope for healing. It is not enough to just be physically safe. It is necessary to also be psychologically safe. Surviving and thriving happens when a child is safe, secure, and attached. Shared parenting helps heal trauma. Shared parenting is a collaborative arrangement between two or more adults that have joint responsibility for the care, nurturing, and decision-making for the same child. Shared parenting is to promote ongoing positive interaction between birth parents and resource parents so that birth parents can be active members in the alliance focused on the well-being of their child. By encouraging birth and foster parents to share decisions and work together as a team, shared parenting maintains the birth-parent-child relationship, improves birth parents' self-esteem, helps foster parents form a realistic picture of birth parents' strengths and deficits, and gives birth and foster parents more information about the child. Shared parenting allows the foster parent to model appropriate behavior and parenting techniques, helps birth parents develop an understanding of the child's needs, facilitates eventual reunion, promotes ongoing support for the family after the child returns home. Overall, the person who receives the biggest benefit when everyone works together is the child. We now will watch a media presentation that features Dr. Bruce Perry, an expert in the area of childhood trauma. This presentation is Trauma, Brain, and Relationship, Helping Children Heal. The presentation brings together everything that we have discussed so far in this session.
Everything that's important about life as a human being, you learn in context of relationships.
We need somebody that we can trust, that we can hold on to, who walks with us hand in hand through the whole deal.
Brain research gives us the new lens in which to begin to look at children's behavior and the meaning of their behavior in a completely different way.
They'd found that if you took a little rat pup and you held it, a human being held it for a very brief period of time, which was stressful to the rat, and put the rat pup back in the litter with the mother, let the rat grow up, and then looked at its brain, it was different than animals that hadn't been handled.
Early in life, many of these connections in the brain, what are called synapses, develop based on genetics, but also based on how experiences occur. And then throughout childhood, the changes in the brain that occur in an interaction between genes and the experiences kids have.
The research on the brain has for the first time given us biological, physical proof that interactional processes that don't go well, for example, impact the brain profoundly.
If the brainstem, for whatever reason, has some insult during development, it could be alcohol exposure in utero, it could be cigarette smoking, it could be prenatal exposure to drug, or it could be significant distress in the caregiver. For whatever reason, if the brainstem is poorly organized and overreactive and dysynchronous, the baby's born, and very often they will have what we call a state regulation problem. They are hard to soothe, you can't quiet them down very well, it's hard to engage them, and it makes the caregivers feel overwhelmed. They can't calm the child down very well, the child stays all stirred up, and instead of having this smooth, synchronous interaction, you have kind of this bad fit.
When a pregnant mother is under constant stress, you know, she might just be stressed at the office, but her brain and her body and her developing baby's brain don't know the difference between that and that there are predators in the environment. So we're seeing babies being born that are hyperreactive. Why? Mom's under stress during her whole pregnancy, either through work or through being unsupported by her community, by her partner, by her family, whatever. So we have this baby born that's already hyperreactive.
The attachment bond between the parent and the child is really the carrier of all development, and the regulation that a mother provides, the soothing that the mother gives to the baby, the calming of the baby's nervous system. If she can do that well, the baby's nervous system will learn how to regulate itself. If she cannot do that, if she herself is all unregulated, if she is sick, if she's in marital discord, if she's depressed, she cannot attend adequately to her baby to where the baby feels like there's somebody there watching out for him or her, then the baby goes into these heightened states of hyperarousal and dysregulation, and the body, the template of that, is being set.
Attachment relationships where the parent is sensitive to the child's inner state lead the child to have a brain that becomes very integrated and a mind that is very coherent.
What our bodies want for best development is relationship. Every neuron in our brain develops most optimally through a loving relationship.
The most important pivotal experience in a child's life is that a caregiver and a child have a falling in love experience. And that experience of joy is invigorating to the body on all fronts, and is essential to being able to develop the capacity to care, to be able to develop the capacity to love, and to have empathy for other human beings, and to be able to have moral conscience.
Relationships are the absolute heart of humanity, and we are neurobiologically designed to be in relationships. We are neurobiologically designed to be able to read and respond to other people, and we're neurobiologically designed to reach out and seek relationships with other people. And when we have these opportunities to form healthy relationships with family, with neighbors, with coworkers, with members of the community, we're healthy. And when we don't have those opportunities, we literally are physiologically at risk.
Children, infants are not soothed, repeatedly not soothed by their parents when they're in distress. That impacts one of the chemical systems in the brain, what's called the cortisol system. And cortisol is a natural neurohormone for calming arousal down, calming distress down. And if an infant's not soothed, then they increase their cortisol levels to try to make up for the lack of soothing by the parents, self-soothing. And then because high levels of cortisol are dangerous to brain tissue, it resets the thermostat. And that as a result of that, through the rest of their life until recently, we thought it was permanent, the thermostat is set so that they have less cortisol and less capability of handling distress. So they're more prone to getting upset, more prone to staying upset once they get upset.
If parents are not providing sensitive caregiving, where they're not tuned into the internal state of the child, then you have various kinds of difficulties that can arise.
Developmental trauma, including neglect, has as high an impact over the lifespan as a single incident trauma.
Developmental trauma or ambient trauma is trauma that's just everyday life. It's in the neighborhood, it's in the household.
It is at times very confusing to the adult world the way children respond to traumatic events, and it's very easy for adults to dismiss the profound impact that a traumatic event can have on a child, because very often they will do most things pretty well.
There's a strong sense that children are there to manipulate us and to be willfully disobedient. And instead of really understanding the child from the child's point of view, I think we've imposed something from the outside almost adult characteristics onto children.
One of the single most important understandings that parents can have is to realize that trauma creates fear in children, and anger has an underlying element of fear. And so instead of focusing just on the anger, we can address the fear in children and calm and soothe the fear that will make the anger go away, rather than just focusing on the anger.
Children who have experienced some type of trauma often have symptoms of ADD.
These difficult behaviors are really stress responses, and it's up to us to figure out what is causing these stress responses. And there's several different pathways that they can show us that they're distressed. The first stress response is a hypersensitive, hyperreactive stress response. And these infants cry a lot, are inconsolable. When they become toddlers, they may go into rapid temper tantrums and be very volatile. A second stress response are infants who are hypervigilant. These infants will have very wide eyes and will be very vigilantly looking, and you can see that there's an anxiety in their muscle tone and in how they carry themselves, and that they're scanning the environment. A toddler may be overly clingy or overly withdrawn. A third stress response would be very shut down and tuned out. These children, again, may be misunderstood as a good, easy baby.
There are equal number of children who are too good, too quiet, withdrawn, who demonstrate the cool side, the shutdown, the frozen side of trauma. Most teachers, most educators at this point still don't recognize those kids, and they often become as problematic or more problematic than the more obviously upset kid.
You can't always tell when a child has been traumatized. Very often they may be going through the day interacting normally with their peers. They'll be playing games, they might be laughing, and you may not have any idea that that child the week before lost their parent in a violent event. However, if you follow that child long enough, what you'll find is that under the smallest challenge, they'll unravel and they'll unwind. And it's not always predictable. They may handle one situation very well and then completely collapse in something that seems pretty minor.
When an attachment figure is the source of terror, the child's brain has two processes going on at once. One is the inborn attachment system, which says, I'm in a state of alarm, I need to go to my attachment figure for soothing. But if that attachment figure is the source of the distress, and I don't just mean being upset and you don't get ice cream before dinner, I mean terror, then what happens is the child will then try another track in the child's brain will state, do not go toward that figure, that's the cause of your distress.
Parents are unaware of how that they can traumatize their infants or their toddlers, and then they're unaware of what their children's signals mean.
People who are traumatized are stressed, and the stress doesn't go away. The symptoms don't go away. They persist in one way or another, either as a psychological problem or as a learning problem or as perhaps a physical problem in the body. For years and years and years, they never disappear. They come, they go, but they're always back again. That's trauma. That's stress at the level of trauma.
98% of parents who have children who have been traumatized have also been traumatized themselves. So healing the parent's trauma first allows them to create an environment for the healing of their child's trauma.
If you really want to understand how a child is functioning in the present, you need to understand their personal history. Because the brain, more than anything, is an historical organ. It stores experiences. So if you understand the personal experiences of the child, you will understand a lot about how different systems in the brain are organized.
We look at the whole person, we look at their whole history, and we look at their development. We look at what's happened in their body, in their life, in their social structure. We look at all the aspects of their life, and then we determine where to go from there.
One of the most important factors in a good developmental history is getting some understanding and some insights about the child-rearing beliefs and practices of their caregiver, which you can usually get by asking them about their family and the way they were raised.
We have to work with parents who can feel good enough about themselves so that they can allow their children to feel good enough, and there won't be the kind of abuse.
It is essential to treat the entire family when healing trauma in children. Without healing the trauma of the family and creating awareness for the family, you can't heal the child.
It's a parent's own self-understanding that is so crucial for the quality of the relationship with the child. Trauma is like a dog bite, in the sense of when a dog bites you on the fingers, your natural instinct is to pull your fingers away, and unfortunately that will create more damage to your skin. What really you need to do if a dog bites you in the hand is thrust your hand into the dog's mouth, which makes the dog gag. Now, I know it's very graphic, but it's the same thing with trauma. Parents need to know it's important to go into the trauma, into the mouth of the trauma with your mind and with the relationship, so that it doesn't dig its teeth in and yank the flesh of your soul away.
First of all, we have to get our children and our infants back into a condition of safety. That may be that they need contact with a safe relationship, that maybe they have had a disruption and they need to maybe not go to school that day and spend time with mommy, and maybe mommy needs to not go to work and just spend time with her child. So they need to get to regain a sense of safety if in fact that has been their baseline. One of the ways we help infants and children regain a sense of safety is to start to become what I call a sensory detective. We need to start becoming really aware of what sensations are reminders of that traumatic event, and they could be sounds, they could be tastes, they could be something visual, they could be a particular movement, a particular touch. And we're going to reintroduce a sensation that has been very traumatic or that triggers a traumatic memory. We want to be very clear that we give the right dose that the child or infant can handle. So it's going to have to be very small increments of helping them be able to experience that sensation, recover from that sensation, get back into safety, and then slowly go back and forth between a sense of fear, feeling out of control, and then being able to get back in control and safety. And the fourth is to increase the child's surround of sensory comfort so that beyond the caregiver, there can be many arenas of sensory comfort that the child or infant can surround themselves with, whether it's music or a particular touch of a blanket or a particular toy that they hold that they feel safe with.
The next phase, though, is to tell the story of the experience, to make a narrative of it, so that other parts of the mind, and the brain, if you will, the left hemisphere, can join in the process of making sense. It also involves the verbal aspect of the creation of a story from before the trauma happened, what happened at the time the trauma began, what were the elements of the experience of the trauma, what was the most frightening part, how did the trauma resolve,
what surprised them, what they didn't expect, what their body felt like, what it felt like in their body, what it felt like in their emotions. Can they tell us what those emotions are? Can they get pictures and put together the story?
What the narrative experience tells us is that what's shareable is bearable. And so when a person can bring it out and share it with another, then it becomes more bearable than keeping it to yourself.
A lot of the trauma that has happened to children happened before they were verbal. There's no way we're going to work with that verbally. We have to get into their senses.
With infants and young children who are pre-verbal, there is still a way that parents can communicate to the child that they are understanding their child's distress and the importance of that. And they can communicate the story and the narrative of understanding I understand what happened to you, even though the child may not completely understand the language of it, they will understand the tone of voice, they will understand the rhythm and the rate in which that's communicated.
Half of our brains, our right half, can only speak the language of the nonverbal. And the nonverbal includes eye contact, then there's facial expression, tone of voice, posture, gestures, and timing and intensity of response. Those nonverbal signals can be taught to parents, and they can use them to understand what's going on with other people, especially what's going on with young children.
Early childhood trauma changes the biology of the brain. Well, early childhood support also changes the biology of the brain.
What studies of resilience show that even when children have insecure attachments in the home, if they've had at least one secure attachment with a daycare provider, a preschool teacher, or another adult in their lives, then that makes a huge difference for them having the seed of resilience. They may still have difficulties, but because they've had that one secure relationship, that relationship where they felt that another individual, another adult knows them and feels what's going on inside of them, those kids have the potential to do very well in the future.
We can see imaging today of before and after trauma and see what happens in the brain, and we can also see repair that happens in the brain when our interventions have been successful.
What makes children get better following a trauma is connection to other human beings who are present, who are patient, who are kind, who are sensitive, and they don't need to be necessarily psychologically insightful. They don't need to know anything about trauma. All they need to know is that they're right there with this child, they're trying to be comforting, they're trying to be supportive, they're trying to encourage. Those kinds of interactions end up being much more therapeutic and healing than many of the other things that we try to do with kids.
Teachers can look more at their children, be more emotionally present for children, touch them, work on their own nervous system and their own regulation. If they're angry and they're out of control in terms of what's going on inside of themselves, the message that they're going to convey to the child is, I'm angry and I don't like you.
If you're an adult and there are children in your life, whether you're in law enforcement, a teacher, a parent, a foster parent, whatever you are, and you know that a child has been exposed to something that's potentially traumatic, the first thing that you should be aware of is that not all traumatic events lead to disastrous mental health outcomes. In fact, the vast majority of children that are traumatized actually do pretty well, but they do need your attention, they do need your kind support, and they do need your awareness about what are warning signs that would tell you to actually take the next step and try to get some professional help.
It's up to us. We can't wait for a they to do this spreading of the message that we can do something about it, that children, especially young children, have the most possibility for health and plasticity, for overcoming these early traumas if we as a community, a large community, support them.
We have permission now to meet children's needs. We have permission now from neuroscience to give children what they need, and to me that is so exciting.
If there was one place I would like to start with individuals as well as our society trying to make a difference, to really stop the cross-generational passage of trauma and of insecure attachment, it would be for parents to start a process of self-understanding. It basically costs nothing except the time and emotion that it takes for parents to begin on that process. And we all can do it. And the people who benefit most, besides ourselves, are our children.
We're spending literally 95% of our public dollars to change the brain, because that's what mental health is. That's what public education is. That's what juvenile justice intervention is. All of these are trying to change the brain, and we're spending almost nothing in the first 5 years of life when the brain is easiest to modify, and it takes the least amount of professional input, the least amount of insight. It takes just high-quality caregiving.
It's us, not they. It's each one of us doing it now, not later, but now.
So, we want to connect and safe up our children. We want to teach children to move themselves from the state of dysregulation to a regulated state. In reviewing this slide, we note that behavior changes when we teach and guide children by letting them know what behavior is acceptable in a way that is firm yet kind. Research has shown that individuals learn best when they feel safe and connected to others in contexts of safe relationships. Therefore, the goal is to teach by first creating safe relationships with children. Connection must come before correction in order for behavior to change to be effective in the long term. The most powerful tool for teaching children is modeling what we want them to do or to be. How does relearning response occur? Process of understanding that the response to the traumatic event was needed then, and that it was indeed a survival response. Understanding that the threat is no longer present and the trauma response is no longer needed. Identification of trauma triggers, release of stored trauma, and learning new responses. We briefly noted that our children are connection-seeking rather than attention-seeking. This one statement is worthy of restating. When we are aware that our children are seeking connection rather than attention, it drastically alters our response to their behavior. There is a difference in that we recognize connection-seeking behavior. We need to move in, enter the circle of the child rather than isolate the child, and focusing on the behavior. Look at the feeling under the behavior. Name it, talk about it. Be there. Of course, a child cannot hurt themselves or others, so it is necessary to ensure safety.
Dealing with trauma-induced behaviors. We want to make sure that our children know we see them. We want to recognize that they are dealing with big feelings, no matter what age they are. We want to help children begin to recognize when the big feelings are about to start. We want to give children permission to feel and to go to a safe place if needed to calm themselves. There are some excellent examples in the short media presentation, Head Start Trauma Smart. We'll watch this presentation now. It's helpful for you to make note of some of the strategies used to teach children to calm themselves. Please take a moment to watch this Head Start Trauma Smart video.
It was about 2 years ago when my grandson, Jeremiah, at the age of 2, witnessed his father shoot and kill his mother in her car, and then it was a murder-suicide.
But does the mommy go on the bus?
No, please don't feel
and him and his brothers were strapped in their car seats in the back seat.
We're going to the hospital.
There's no words to put in place of how that feels.
At Head Start Trauma Smart, our goal is really to help young children, their caregivers, their family members, the teachers who work with them, really understand how trauma affects early childhood development and then what to do about that.
Across the general population, 1 in 4 children will experience a significantly traumatic incident before they're 4. The number that really gets your attention is that 50% of those children will experience that 3 or 4 times. We've started with Head Start programs because that commitment to early childhood intervention is very, very strong. The children are really seeing a lot more than they can explain. And what happens is that they become hypervigilant, they are tired, they startle easily, their hearts beat rapidly, and they can't focus. So sit down, come to the table, and learn with us. Even if I want to, probably isn't possible.
You want your mommy? Well, I know you want mommy, but you know what? You're here with me and you're in a safe place. I went through the Head Start Trauma Smart program for, I believe it was a whole year of training. You want to sit by Raymond? Did you ask Raymond if it's okay if you sit by him? They showed us how to use the tools and implement it into the classroom. It has helped me tremendously. When a child is upset, the first thing I do is I notice that they're having big feelings. Then I'll speak with the child and I'll name, hey, Joseph, you're having a big feeling right now. And then I'll validate. It's okay to have that big feeling, but what can I do to help you? Want to breathe in and breathe out.
For Jeremiah, we have had an ongoing concern with him being able to express how he feels.
Yeah.
Being able to ask for what he wants. When the murders first occurred, it was a lot of just standing there pointing or waiting, and you had to ask, Jeremiah, are you hungry? And Head Start Trauma Smart actually got us on a path where Jeremiah is able to now say how he feels.
We are absolutely very focused on the children, but to be focused on a child, you have to understand they come in context. So they come in context with a family.
We just want to equip you as parents with as many tools as possible to support your child.
They come in context with their school.
Your emotional state becomes the emotional state of your classroom.
And so you must include their family and the people in their school. So that might be the bus driver that greets them every morning. Whoever it is who's touching that child has to also know how to manage their emotion and their day-to-day living.
We are the first people that the children will see in the morning. I really applied what Trauma Smart taught me.
Within Head Start Trauma Smart, there is a very healthy dose of that whole self-care piece, because the adults in the environment, the parents and the staff, were struggling themselves with secondary trauma.
So what face is this?
Sad face. Could I see your sad faces? Let me see your sad faces. Oh, those are so sad. That's a real sad. Let me see your mad face.
And you have to have enough within yourself to be able to respond appropriately with the child.
Head Start Trauma Smart is currently in a growth phase. We are expanding this program across the state of Missouri. We know that we can't stop bad things from happening, but we can really make a difference so that people can survive those bad things and then know how to thrive after they've happened.
I need for Joseph to lead us in head, shoulders, knees, and toes. Now that I have those techniques from Head Start Trauma Smart, I can breathe, I can teach, I can deal with the social emotional issues on one hand and I can teach on the other, and still have a classroom environment that's a community, that's learning, that's caring and safe for our kids.
We've talked about using already established connections to help with healing. For example, who did you always want to come to see you? Who was your next favorite? Explore with your DCPS worker. Can we connect the child with these safe people? There are some other activities that help with brain healing. These include, but are not limited to, music therapy, art therapy, yoga, dance, boxing, exercise, walking, running, creating, and equestrian therapy. You play a vital role in helping children and families heal. Shared parenting, support, and empathy are the tool you own to do this very important trauma work. Here are a few additional resources to help you. Thank you for your commitment to intervening where it matters most for the children and families we serve.